Thank you for coming out tonight. I know it's not a very nice evening, but we've had a lot of nice evenings this month, so we'll take a little bit of rain today. So my name is Mary Lynch. I'm the Member Services Director here, and I've been in contact with you guys in various hallway conversations and emails and everything else. So thank you for coming tonight. We haven't had a wellness event in a while, so we're happy that you guys are very interested in how your feet are doing. So also, I just want to throw in, if you can silence your phones, that would be fabulous. We're going to try to hold questions to the end. So if you need to jot something down or whatever, we'll get you some pens and paper. I think there's some paper around to do that so you don't forget what that is. And also, because I'm the one that schedules all these and is always thinking about what we're doing in the future, if you guys have great ideas or, hey, what about a talk on whatever, email me, let me know. See me in the hallway, whatever works for you guys. We do have one coming up, tentative October. We do have one coming in November on sleep. Yeah, so I'm signing y'all up right now.
Yes.
Tentatively, that's Wednesday, November 12th. And that's being done by a woman who's a nurse practitioner, focuses on women's health and weight management issues and such. So she is like really strongly about sleep being that piece of the puzzle that a lot of us are missing. I don't know. I haven't seen the slide deck yet, so that would be being awake though. So we're gonna focus on sleeping. No, kidding. I haven't seen the slide deck though, so I don't know exactly. But as soon as that comes together, you'll see that advertisement. We'll get that out. So
will that be in the evening as well?
Yes. Yeah. Oh, I gotta change the date. And like we've got a couple of that live on our website right now. We are recording this one. Hopefully it'll go well. Our usual social media gal is not available tonight, so the kids, as I call them, down front got this going. So hopefully everything will work, and then I'll let you guys know about that, and that will live on our website as well. And there's 2 that are there right now if you wanted to reference those. But I will let these guys introduce themselves. Thank you for coming.
Thank you.
Yes, my pleasure.
My name is Bobby Corbilla. I'm a foot and ankle specialist. I work at Mobility Joint Institute. And thanks for coming out tonight on this rainy night to hear about the foot. The last time I was here, I talked about heel pain. That's a very easy topic for me to talk about because everybody has it. It's the most common thing that I see. But this was a very challenging assignment. This was a very challenging assignment because this is so broad. Because there's about 80 or there's only one thing that can cause heel pain, or really one thing that causes 99% of heel pain, but there's about 80 or 90 different things that can cause midfoot and forefoot pain, and they're all different. So trying to narrow it down so that I can get out of here before midnight is very, very hard. So first, when we say the midfoot, we're really talking about the foot is now divided into the hindfoot, midfoot, and forefoot. So what we're going to talk about tonight is everything in front of the blue line. So the forefoot is divided into 5 toes that have 2 bones in the big toe and 3 bones in the lesser toes, which are toes 2 through 5, and then the metatarsals. The metatarsals are the bones that lead up to the toes. You sometimes might refer to it as the ball of the foot, but those are the metatarsals. The midfoot is a very complex structure. There are 5 bones and 10 joints. So it's not just the midfoot, it's actually 10 separate joints. And they can all each individually become painful. But it's a very important part of the foot because that's the shock absorber of your body. Every time you take a step, those joints in the middle of your foot bend, buckle, and that's how you absorb shock. And they're bordered by everything at the top blue line, which is called the Lisfranc joint. Lisfranc was Napoleon's surgeon, and when his soldiers fell off their horses and their stirrups got caught, they would need amputations, and he did it. Jacques Lisfranc, he was a French surgeon, and now everything is named after him because he did that. The Lisfranc's joint, Lisfranc's ligament, Lisfranc's injury, which is a twisting injury of the midfoot, and then the bottom joint is called Chopard's joint, and that is named after Francois Chopard, also a French surgeon, who, by the way, was a urologist. And I don't know what he has to do with foot and ankle surgery, but he performed an amputation on one of his patients, and now everything in that part of the foot is named Chopard. So trying to make this talk last under 5 hours was very challenging. So what I did was I tried to divide them into trauma, deformity, and arthritis. And amongst those three topics, just pick two, one each in the forefoot and midfoot. So we're really going to talk about six things: stress fracture and fifth metatarsal in under trauma, deformity, hallux valgus, which is also known as bunion, and metatarsus adductus, which is related to a bunion, and then arthritis. Not all arthritis, not every single kind of arthritis, but two specific kinds of arthritis that affect the forefoot and midfoot. We're going to start with trauma, and the first thing we're going to talk about is stress fracture. So the best way to describe a stress fracture and how I describe it to my patients, it's like if you took a pencil and you bent it and you heard it crack. So you stop bending and you put it back on the ground. It looks like it's still a pencil, but it's not, it's broken. And that's what a stress fracture is. And it can happen in the bone for one of two reasons: minor trauma, you fall off the roof, you're going to break something in half. But if you jump off this table, you might hit the bone just right where you get that crack, like that pencil. The other reason is from repetitive stress. So just like a bridge where a billion cars goes over, eventually the stress is going to cause it to fail. The same thing can happen with bone. If you do a lot of activity, it'll eventually give out and that crack can develop. After the marathon, some of my patients will come in and they'll say, "I think I did something wrong. I was the marathon, nothing happened to me, but my foot hurts. Maybe I broke something." They get an X-ray and there's nothing there. 3 weeks later, they'll come back and they'll say, "It still hurts." Then when we get an X-ray, we'll see this halo of bone that you see the arrows pointing to. That's called bone callus. That's a healing of a stress fracture. So that's often how you diagnose a fracture. You can get an MRI and it'll show it immediately, but how we often see it is it this way. How we see it. Yeah. I mean, if you see that, no, that means it's healing. That means you don't have to do anything. That means it's going to get better. It will still hurt, and there are ways to manage that. So we'll get to. There's a second condition that's similar to stress fracture. They present very similarly, and that's called metatarsalgia. That's why I have to include it here, because they come in exactly the same. While my foot hurts, and one it's a fracture, and the other one it's metatarsalgia. So one of the things we have to do is try to differentiate: did this person have a stress fracture, or does this person have metatarsalgia? Metatarsalgia is a little bit different. They present differently. Usually with stress fracture, that's why we have to listen to the patient, what they say, how this start, what happened. Because with stress fracture, it may not be a marathon. It could be, well, I just took up walking. I went on a hike when I was on vacation. So there's usually a sudden onset. Whereas with metatarsalgia, it's something that gradually gets worse. So with metatarsalgia, there's a deformity. Something is wrong with their foot. Usually, there's one of the metatarsals, like here, that arrow is showing the second metatarsal is much longer than it should be. So that's where the pressure is going to be, under the knuckle of their second metatarsal, just behind their second toe. It could be that one of them is angled down more than it should be. Normally they're angled down at 15 degrees, and if they're angled down a little bit more, it's going to hurt. You're going to get a bone bruise there. And these are things that can gradually develop over time. So you may not have been born with, maybe the length is the same, but the angle may change over time. So it might be something that you see change over time. And sometimes a callus will develop because of this pressure. So you'll see a callus where that pressure spot is. And that's called metatarsalgia. So the next thing, how do we manage these things? How do we manage a stress fracture? It's managed with a boot. It's a mobilization. So you can walk on a stress fracture. You just need to protect it. So this boot transfers the weight from the bottom of the foot to your shin, so that you can put weight on it without making it worse. And typically they do very fine. It's very rare that you have to operate on a stress fracture. Another thing that I'll add for both conditions. So when someone comes in with a stress fracture, they'll say, "Well, the boot might help this heal, but it doesn't make it feel better." So what I'll do is I'll have them wear a metatarsal pad for both conditions, from metatarsalgia, from the long second metatarsal, or from a stress fracture. This is not a cushion. This doesn't go under their fracture or their pain, because that would make it worse. That's like putting a rock under the rocket cushion. This goes back. So you're putting it in the middle of your foot so that the knuckles, where the pain is, does not hit the ground. So the pain is at the knuckle, you put this behind it. You can, like in the case of metatarsalgia, this might be an ongoing problem. It's not, unlike a stress fracture, which after 6 weeks or so is going to get better. Metatarsalgia, the long second metatarsal, is going to be with you forever. So in those cases, they'll modify their shoes or their insoles. And what they'll do there is what I instruct them to do is just take red lipstick or a red marker, put it on with a spot that hurts, and step on your insole, and then put the metatarsal pad behind that red mark. So now when you step on the insole, your weight is here, not on the spot that hurts. The metatarsalgia people often describe as it feels like I'm walking with my socks bunched up, even though my socks are not bunched up. Will feel like I'm walking on pebbles. This takes the weight off of that spot, so it doesn't feel that. In stress fractures, if they don't get better, they're rarely operated on. You'd have to do something really bad, like like jump up and down on it, make it a real fracture for us to need to operate on it. But there are cases where stress fractures don't. That's called a non-union. A non-union is a fracture that hasn't healed in 12 weeks. There are other things that can cause that, like if you're diabetic or if you're a smoker, that can delay healing. And in those cases, we'd use something called a bone stimulator. A bone stimulator is an electric device that sends an ultrasound pulse to the fracture site and tricks it into healing, so to speak. It's there's a principle in bone healing called Wolff's Law, and in Wolff's Law, the more pressure you put on a bone, the thicker it gets. So a marathon runner's foot is going to have thicker bones than someone who sits all day. The opposite is true too. When astronauts go into outer space, they lose their bone mineral density. So that's Wolff's Law, that the thickness of the bone is proportional to the amount of pressure. So this takes advantage of Wolff's Law, and that ultrasound pulse tricks the body to thinking there's pressure there without actually putting pressure there, and that helps stimulate more bone. So when you have a fracture that does not heal, or if you have a fusion that doesn't heal, this is the device that we use. In metatarsalgia, there's unfortunately when that doesn't get better with padding, and it almost always does get better with padding. But some people don't want to use pads in their foot if they have metatarsalgia or they have a really bad deformity. There's an operation called a Weil osteotomy. It's where you just shorten the bone. It looks very complicated, but it's not. You're actually just shortening the bone by making a cut straight across here, a straight back, and then shifting it back. You can walk on this immediately because it's a very stable cut. If you walk on that, it's actually going to help it to heal. So you can walk on that, and it shortens the bone by about 2 to 3 millimeters. And afterwards, there's hardware that keeps it in place so it doesn't move back, and it relaxes the toe. So if you have a toe that looks like this, make a cut in the bone and slide it back to break the toe down, and that will also get rid of the pressure spot. Next, fifth metatarsal fracture. I chose this because this is the most common fracture that I see, and it's very easy to do. You don't need to fall or drop something on it. All you need to do is twist your foot. You'll get a fracture of that spot where that red arrow was pointing. So if you invert your foot, this is very easy to do. You miss a step, you step into a hole in your backyard, and what ends up happening is there are 2 strong tendons, the peroneal tendons, that attach to the base of the fifth metatarsal. So when you twist your foot like that, those tendons will pull a piece of that bone off, and it'll cause a fifth metatarsal fracture. So this is a twisting injury, and those tendons are pulling a piece of that bone off. This is extremely common. I probably see 1 or 2 of these every single day that I'm in the office. And this is what it would look like. So that beak that's pointing down is called the styloid process, and that's where the peroneal tendon attaches. And when you twist your foot, that tendon will pull a little piece of that off. Sometimes this is referred to as a dancer's fracture. Dancers can get this kind of fracture. That fracture, even if it was bigger, is a benign fracture. Sometimes patients get very anxious when they see this and look at it. It's, this is something awful. This will almost always heal very uneventfully. In 6 weeks, you can walk on it. You can take the boot off to drive even if it's your right foot. So this is not a bad fracture. This next slide, which looks very similar to the last slide, is a bad fracture. It's right here, this crack in the bone right here. Mary, do you have a pointer? All right. That this looks very similar to the last slide, but this is a very different fracture. This is called a Jones fracture. So this is the same mechanism. You twist your foot, it pulls the bone off, but that location is a very unfortunate location to get a fracture. This is named a Jones fracture after Robert Jones. He was a military physician about 125 years ago, and he was dancing. Had a lot to drink, and he fell, and he broke his fifth metatarsal, and he spent his life studying it because his did not heal properly. And what he found was that the base of the bone has very rich blood supply. That's why he can walk on that fracture, and it did very fine. The end of the bone has very good blood flow. The middle of the bone has its own artery, but the base where that green line is has very poor blood flow. So if you get a fracture, if you're unlucky, and it's very rare to have that, you will have a fracture that takes a very long time to heal or won't heal at all. Sometimes they require a couple of operations, where bone graft in, and screw in. So that's not a good fracture to get. So initially, fifth metatarsal fractures are treated with a boot, and the first kind that we saw, it takes about 6 weeks, and after 6 weeks, you're out of the boot with a regular shoe. And rarely do you need physical therapy, though sometimes that tendon that causes this fracture becomes injured as well. So they'll need physical therapy if that tendon is injured, and they'll have trouble moving their foot side to side. That's what we'd send them to therapy. Most of the time, they don't need that. If it doesn't work, like this is a picture of a non-union. In a non-union, no bone is growing across it, and the edges become hypertrophic. That means that the edges of that fracture are thicker. So it's growing, it's just not growing toward each other. And that's called a hypertrophic non-union. That's what it looks like. So if you see that, that doesn't always mean that the next step is an operation. Some people get painless non-unions. It's like there's something holding that bone together. And I'll see them at 6 weeks, at 12 weeks, and 20 weeks, and I'll look at the x-ray and it looks awful, but they don't have pain. And you can leave those alone, because that means something is holding the bone together. It's usually not bone, it could be soft tissue or connective tissue, but that doesn't need treatment. You need treatment if that is causing pain. And usually non-unions like that are very painful. Like every time they take a step, they'll have pain on the side of their foot. If you do, there's fixing it with a screw. It's usually a single screw that goes, I make a small incision on the side of the skin and then put the screw over the wire. And it's a very common operation, but it's usually done when you get a non-union open. It's not done for all fifth metatarsal fractures, and not even done for all non-unions, because some non-unions don't need a treatment at all. The next thing we're going to talk about are the arthritic conditions of the foot. So the first we're going to talk about the arthritic conditions of the forefoot, and this is probably one of the top 5 things that I see. It's called hallux rigidus. Hallux rigidus is arthritis of the big toe joint. It causes pain, stiffness of the big toe joint, and sometimes a bump. So patients will come in and say, I have a bunion, but that's not a bunion. This is hallux rigidus. It's actually worse than a bunion, because bunions are rarely painful. Hallux rigidus is always painful. So the normal range of motion of the big toe joint is 70 to 90 degrees. So if you drew a line from here to where you can lift your big toe up to, it should be roughly just under a right angle. If it's less than that, that's how you know you have hallux rigidus. And that's why it's called that. Hallux is another word for the big toe. Rigidus, because it's rigid or stiff over time. And as it gets stiffer and stiffer, you'll start to develop a bump. That's the bump on top. This is an extreme example. It's very rare to see a bump that big. But this is an example of hallux rigidus. On X-ray, you'll see first the joint start to narrow. Then the cartilage under the joint will become thicker. So that's that white line. It's called subchondral or under the joint sclerosis or thickening of bone. Then the joint will start to disappear. And then in the final stages, bone will grow around it. The body will treat it like that bone is actually, when there's no cartilage, the body treats it like a fracture. We saw the bone callus earlier. This is a form of it. It's like healing it like a fracture. So these are the stages of hallux rigidus. You don't need any fancy tests to diagnose it. If you just do the range of motion exam, if you palpate the joint and it hurts when you press on it, and put them through a range of motion and see that it's less than 70 degrees, that's how you diagnose hallux rigidus. Conservatively treating hallux rigidus, inserts like orthotics make it worse, because you don't have room in your shoe. If you put something in there, it's gonna take up the little room you have in your shoe. There are some inserts that have shown some benefit. The goal of the insert, like most inserts are made for flat feet. They lift up your flat foot. But the goal of this insert is to stop your big toe from bending, because if your big toe bends, then it's going to grind, and the cartilage that you have left is going to go away. So that insert is called a carbon fiber insert. It is paper thin, made of carbon fiber. It does not bend. It goes up the side of the toe where your big toe is, and prevents that side of the foot from moving at all, so that you can wear that and it'll prevent it from getting worse. It's not a cure for it, but it stops it from getting, like if you have 50 degrees of motion, from getting to where it's 0. Another conservative option that allows you to remain active and still use your foot is this. This is called a rocker bottom shoe. A rocker bottom shoe is one where the bottom of the shoe is roughly shaped like a rocking chair so that your foot rocks, so your big toe doesn't have to bend. Um, this is a really great tool against hallux rigidus because I have hallux rigidus myself. I have a mild form of it. I have about 50 degrees of motion. I would never know that I have. I don't walk, I don't run, I don't hike. I barely walk from my car to here. I swim for exercise, so I would never know that I have this. But about 10 years ago, some of my friends were down in the military. They do a charity race called the Tough Ruck, where you have to wear a 50-pound backpack and hike 26 miles. So they signed me up for this, and yeah, they didn't tell me. And then we trained together, and I got to about 8 or 9 miles, and my big toe was throbbing. So I knew what I had. So I told them I'm only going to do 8 or 9 miles. And about a week before the race, one of my patients told me, "Well, why don't you just wear rocker bottoms?" And so I did. I didn't even have time to break it in. I finished all 26 miles, and I felt like I was cheating, and I should give it a medal. But this is what I recommend for hallux rigidus. It's a great way to maintain your activity level and not have to worry about your big toe. If that doesn't work, there are other treatment options like oral or injectable steroids. So they're the same medicine, just one is by mouth and one is by injection. And if that fails, only is there surgical intervention. And there's 3 different kinds of surgery for hallux rigidus. The simplest kind is called a cheilectomy. Cheilectomy is just shaving off the bone spur. This is easy to do. It takes about 15 minutes. It's easy to recover from because all you have to do is wait for the skin to heal. You can walk on it immediately. You just have to keep the incision dry so it doesn't get infected for 10 days or so. The problem is it's reliable and predictable, but it doesn't help a lot of people because by the time people have no cartilage, the problem is having no cartilage, not having a bump. So shaving off so this is only helpful when you have, like in that other photo with the big giant bump. If you can't put a shoe on because you have a giant bump, taking it off will help. But that's all it will do. It won't do it. It won't give you new cartilage or give you more motion or anything like that. So then that's called a cheilectomy. I'm going to skip all the stages and go to the last stage, which is where there's no cartilage left and the little cartilage you have is killing. There's only one answer there, but that's to fuse the toe. So you're getting rid of the little cartilage that you have left, putting it together, and then fusing it together with metal. Unlike a cheilectomy, this is not easy to do at all. This has to be done perfectly. Knee and hip replacements can take just 45 minutes or so to do, whereas this takes a good hour, hour and a half. And the reason is it has to be placed perfectly. This is patients will often ask, "Well, how am I going to walk after I have a fusion?" You'll be able to walk, and you probably already have a fused toe. Their toe probably doesn't bend, only bends 10 or 20 degrees. That 20 degrees is killing them. So we're getting rid of that 20 degrees and getting rid of their pain. But in order for them to be functional afterwards, because after a fusion, you can run a marathon, you can play golf and tennis and do everything. The only limitation after a fusion is for women, your heel height is limited to 2 inches or less. So that's really the big limitation afterwards. So this is, so in order to do that, it has to be 10 degrees up and 10 degrees in. And that's not easy to do. So you have to do it over and you have to keep working at it while you're in the OR. That's a picture from in the OR. What you usually do is you take the cover that the screws and plates and everything come in and put their foot underneath it and get your finger underneath it. So if you can slide your finger underneath it, that's about roughly 10 degrees. And once you get it in that position, you have to shape the hardware so that it's at that same angle. And that's how you fix it. That's not easy to do. It's not easy to recover from because if you step on that, it's going to break. So you have to wait about a good 4 weeks before you can put your weight on. So it's not easy to recover from. It's not easy to do, but afterwards, the benefits are actually, it's about a 98% successful operation. This has been done for about 50 to 60 years now. So it's a very good, reliable operation too. However, so you can also use fusions to fix very large deformities. People have rheumatoid arthritis. You're not going to fix those with soft tissue procedures. You're gonna restore it by fusing the toe. That's the only way to fix it with arthritis. So it's also an option for arthritis. The other option is joint replacement or arthroplasty. This is done less frequently. This is done because they may not have all of their motion gone. They might still have 40 degrees or so motion left. They may not want a fusion or need a fusion yet. They may not like the idea of their toe never bending again, even though their toe usually doesn't bend. Here, there are several options. One are the metal-on-metal implants, and the other ones are these soft tissue spacers. These sound great, but their outcomes are not great. They've been around since the 70s. You've probably never heard of anyone who's had their toe replaced, like they've had their hip or knee replaced. But because the outcomes on these are not great, they're about 30% of these require revision, meaning you have to take them out within 2 years. In fact, I've taken more of these out than I've put in because their outcomes are not that great, unlike a fusion. But this does exist. The next thing we're going to talk about is midfoot arthritis. Midfoot, like we talked about before, the midfoot is very important. It's a shock absorber of your body. You use it with every single step. Every time you take a step, the middle of your foot bends, and that's how it absorbs shock. And because of that, there's going to be wear and tear on it, and you can get arthritis there, just like you can get arthritis in any part of the body that you overuse. So you'll get pain with walking every time you push off. Most often, patients will have pain on uneven grounds, like if they're hiking on a trail, they're walking on a beach, soft ground. And eventually, this arthritis will cause a collapse of the midfoot. So this is one of the causes of adult-acquired flat foot. So the middle of the foot will become more arthritic, the joint space will wear away, and eventually their foot will collapse and become flat, like in this picture. So that is one of the causes of adult flat foot. On an MRI, you would see the bone around it become arthritic and swollen. So on an MRI, everything is supposed to appear dark. So that's someone's first metatarsal. The muscle is on the bottom there. It's kind of a light gray. The bones are kind of a dark gray. That white where the arrow is pointing is a joint, and that should be dark gray or dark black. It's white because it's arthritic. It's swollen. So swelling on an MRI will appear like that. The options for treatment here, orthotics are a good answer. I'm not a big fan of custom orthotics. I think that they're very expensive, and I'm not sure that there's any difference between a custom orthotic and one that you can get over the counter. But the ones that you get over the counter have to be the right ones. So there should be a goal, like we talked about with Alex Rigidus. The goal of that carbon fiber insert is to stop your big toe from moving. The goal of this insert is to sit in your arch and stop your midfoot from bending, because that bending is going to cause pain. So it has to be somewhat rigid. It has to have structure. How do you know it's a good insert? You take the insert, put it on the counter, a lot of times these inserts have a hole in them, the packaging, because they want you to feel how soft it is. You can bend it with your finger. If it's too soft, your body's going to bend it and it's not going to do anything. But if it has some structure, so the ones I recommend for this kind of a problem is one made of cork or rubber, because those have some structure. Sometimes patients will come in and say, I got this from CVS and it's really soft. And I put it on the counter of my office and I'll bend it. And I think this is not a good one. What I'll do is I'll cut out some felt and I'll reinforce it. And that's so, and then ask them to wear that around. And if it works, then an insert like that is good for them, one made of rubber or cork. Other options are corticosteroid injections, steroid injections into the joints. I use this for two reasons. One, therapeutic reasons. I hope they get better. I hope it goes away permanently. I hope they get a year of relief. If they get a year of relief, it's a good alternative to operations to have injections if they last that long. I also use it diagnostic, because if I inject, so when I see the midfoot, when we saw there were 5 bones and 10 joints, how do you know which one it is? The patient's not going to come in and say, my third navicular cuneiform joint hurts. They're going to say my foot hurts. And so if you inject a joint and they get no relief at all, then maybe you're looking at the wrong joint, no matter what the MRI says or the X-ray says. If they didn't get relief with this, because there are 2 medicines in those injections. There's a numbing medicine, like you have when your tooth is numbed up, and there's cortisone. So the cortisone should give you prolonged relief, but the numbing medicine should at the very least get you numb for a few hours or days. And if it doesn't, then we're in the wrong joint. So I use it to tell if we're looking at, or sometimes I might be operating on a patient and I want to know myself, am I fixing the right joint? And this is one way to tell.
Why would the MRI show?
It does, but it doesn't mean that it matches this. So if the MRI says their first TFT joint is arthritic, but you do this and it doesn't help them, maybe their symptoms are not from. If we MRI'd everyone in this room, there's got to be 1 or 2 or 3 TMT joints that have arthritis. Like I know my big toe joint is arthritic. So it doesn't mean that all of them need to be fused. It just means that you have arthritis, and maybe that's not what's causing your symptoms. So sometimes a joint looks really bad on MRI, but it's not what's giving you the pain. It could be the other joint next to it where it's not as bad on. So this gives you a more accurate diagnosis. It's telling you where the problem is. If you injected the joint and you only get a week of relief, that means the numbing medicine worked, the cortisone didn't, then cortisone is not a good option for that person going forward. So when all of this fails, there's operations. And just like with Alex Rigidus fusions, that's really the only option. There are no arthroscopic options for midfoot arthritis. There aren't any small options. It's taking the joint apart, putting it back together with metal. You can do it to one joint, to two joints, or to all of them. And this, just from like that picture that you can see, which is a foot full of metal, this is not a small operation to do, small operation to recover from. This is always a last resort. Any operation should be a last resort, but especially this one. The last topic we're going to talk about are the deformities of the forefoot and midfoot. And the deformity I picked for the forefoot is probably a very, very common. It's hallux valgus. Hallux valgus is also called bunion. We talked about the hallux rigidus and how that's sometimes associated, called a bunion. So a bunion is not a bump. It's a movement of bone. In a bunion, the first metatarsal has moved away from the rest of the body. This is caused by genetics and lax ligaments. It's not something you did wrong. It's not something that this is not from an injury. This is from a genetic predisposition to getting it. There are certain things like wearing tight shoes that can speed it up. If you're meant to get it, you will still get a bunion, whether you wear tight shoes or no shoes, but tight shoes will definitely speed it up. And of course, they'll feel worse. The symptoms of a bunion are pain in the big toe joint, difficulty wearing shoes because the bump is hitting their shoe, and sometimes pain in the second toe because the big toe is rubbing against their second toe, going under their second toe or over their second toe. We diagnose this like hallux rigidus by clinical exam. You look at it, you say this is a bunion, and you look at their x-ray. And there are some radiographic findings that you see. The first and second metatarsal split apart. They should be parallel. All the other metatarsals, 5, 4, 3, 2, are all parallel to each other. So the angle between them is 0 or close to. In a bunion, that angle widens. And anything over 8 is what we call a bunion. And the other angle we look at is the hallux valgus angle. That should be less than 15. But as this gets worse, the big toe drifts toward the second toe, increasing that angle over 15. The other thing we look at is the sesamoid. The sesamoids are those little pebbles that you see right next to the metatarsal. There are 2 of them, and they are 2 pea-sized bones underneath the big toe. They're inside a they're like your kneecap, free-floating bones inside a tendon. So there are 2 pea-sized bones underneath your big toe, called sesamoids. They help the tendon that moves your big toe flex down. So this is what they look like normally. They're under the big toe, and they're lined up right next to each other, and they're inside a groove. But in a bunion, they are dislocated. And they're dislocated because what happens in a bunion is not just that the metatarsal is moving this way and the toe is moving the other way. They're also rotating. That's actually what the word valgus means. Valgus is a rotation of the toe. So the toe is rotating as it's moving, and it pushes this metatarsal out. And that's sometimes the source of pain. This is a cross section where what it normally looks like and how as it rotates, the sesamoids move. So when correcting a bunion, it's important to look at that and redirect that muscle so that the sesamoids are back under the big toe. There are other conditions that can be confused with a bunion. One is gout. People who have gout have a chemical imbalance that makes their toe, or usually 90% of the time it's the toe, but it can also be the knee and other joints in their body. But when it is their big toe, it's an extremely painful condition. Usually the patient will come in and say, the bed sheets touching my foot hurt. And when you get an x-ray, you won't see a bunion. You'll see a fairly normal looking x-ray, but they'll be a 10 out of 10 pain, where bunions usually are not that painful. The other thing it's confused with is rheumatoid foot. If you Google rheumatoid foot, you will see some of the worst looking feet. These are some of the better ones, but rheumatoid feet are some of the worst feet you will see. And they have a bunion. That's only part of their problem. But these are very painful. And so that's sometimes confused with a bunion. And then, of course, what we just talked about, hallux rigidus, where there's a bump on top of their foot because the joint is worn away. So that is sometimes confused with a bunion. So those are the differential diagnosis of all the things that a bunion. How do we treat bunions? The first treatment is using a wider shoe, but just saying a wider shoe isn't good enough, because if you go out and get a shoe that fits your bunion, but doesn't fit the rest of your foot, it's going to swim inside the shoe. It's going to move more. It's going to rub more. It's going to make it worse. What I recommend is to get a shoe that fits your foot and then use a bunion stretcher. It's a metal device. I wish I had a picture of that. With a ball, and you put it in your shoe and you stretch out your shoe so that just your bunion fits. That way your shoe is properly sized and it doesn't rub against the shoe. Other things you can use, bunion shields. These are silicone devices you can put on your foot that protect it from rubbing against your shoe. If you don't want to stretch your shoe out, this is a good option. Or if you stretch all your shoes out and get wearing wide shoes, but you have to wear like a leather shoe or something for a nice event, this is something you can put under it that'll protect it. And then there are toe spacers. This prevents your big toe from drifting into your second toe. So this is a way to slow down the progression of it. These are bunion splints. You might have seen them online or read about them. These are marketed as being able to correct your bunion. They will not do that. So they're a complete waste of money. So I see a lot of ads for them. Fixing a bunion surgically, the goal is to move the first metatarsal over so that your metatarsal is straight. And when you move the metatarsal over, the toe straightens out. So there are two ways to do this traditionally. One is to break the bone, push it over toward the second, and then fix it with 2 screws. So here you can see the dislocated metatarsal, the first metatarsal, the big angle. So you break it in half, push it over, and put 2 screws in. And that's how bunions have been fixed for many, many years. There's a second way to fix them. That's to fix them at their source. That's to fix them at the base of the bone. So here, you're moving the bone completely over. It also does another thing. It also corrects the sesamoid. So you see how the sesamoid is dislocated. You rotate the metatarsal, put it back straight, and then fuse it with 2 plates. Bunion surgery has always been associated with a lot of complications. It's not that the bunion surgery it's that the reasoning for why you're doing it has changed over the years. It used to be just to get the bump off. Then it was to get the toe straight. Then it was to get the sesamoids straight. So it changed every 10 years. This is really an evolving procedure. So every 10 years, something new is realized. And that brings us to our last topic, actually. And when we talk about our last topic, my mom was a neonatal ICU nurse, and she used to say, "I hate going to the doctor because they're going to find something." So this is one of those things that you find. So when we're correcting bunions, like that is an X-ray of someone who just has a bunion, and you can see the metatarsal is dislocated. You can move that back, and their bunion will be corrected. This person also has a bunion, but if you try to move it back, it's going to bump into number 2, and that condition is called metatarsus adductus, which means all of their metatarsals are adducted. They're facing that way. So this is a condition that is really unrecognized, unrealized, because no one looks at their foot and says, "I have metaductus." It's when they go to fix their bunion that the surgeon will. So if you try to fix this without fixing their metaductus, it'll fail. So that's one of the things how bunion surgery has changed in the last several years is now you have to move them all over to fix their bunion. So that is the end of my talk.
Yeah, but you can stand up right now, shake it out.
Yeah, right.
Do that. Yeah, do that. Most things did it.
All right. So good evening. I'm gonna try to follow up Dr. Carvilla's great talk. I'm gonna definitely relate to some of what he talked about, but I want to talk about a few different conditions. I told Mary one of the things that we hear a lot about in our physical therapy office My name is Neil Washington. Sorry, I'm a physical therapist. Work for Northeast Rehab. You guys have a clinic right downstairs with some of our crew in there. And one of the things we do get a lot. Mary, I don't know if
Skip for now.
just bottom one. Thank you. One of the things we do see a lot. It's still gonna make me do this. Okay, let's see if it lets us do it. We get a lot of questions about shoes and which sneakers are the correct ones to use, which ones are not. Of course, it's gonna do that to us. We'll see if it lets us. All right, maybe it'll let us. We'll see. Hey, you never know. So we'll go over a couple different topics that are sort of relate well to making sure you have the right kind of footwear in place. We get that a lot, and that's often sometimes what we do or recommend for treatment or self-help is making sure you have the right kind of shoes. And that's a topic that, especially in these days, you've probably seen people. I mean, I'm sure everybody in here, a lot of people in here probably have the really thick-soled shoes. That's a big thing right now. It used to really just be one or two brands. Now a lot of different brands have the very thick shoes, especially in the heel and the midfoot. If you go back about 10 or 15 years, it was almost the opposite. They had a lot of those minimalist shoes that were out there that were very thin soled and they had like almost the toes that you could see. So we'll talk about a few different types of things. But what do we hear the most about in physical therapy? Why do my feet hurt? And two things we always hear. I have really high arches or I have flat feet, right? And we hear it a lot and it can cause pain in the arches or around different parts of the foot. And there's different things you can do and we can do in therapy that can help with this. And that's what we're going to kind of go over a little bit today, at least for the first topic. We'll talk about too. So kind of to what Dr. Curvilla said earlier, it's very difficult when you look at the foot to see all the different components, all the different ligaments, all the different tendons. It's very difficult to determine what is causing your pain. I mean, this is the bottom of your foot. So the top part is all the different ligaments and some of the tendons that are sort of resected or cut just in the bottom part of your foot. And then these bottom two sections are all the muscles that overlay all of those ligaments and tendons. So there's a lot of structures in our feet, and it's very difficult sometimes to determine what is causing the specific pain. It could be from one joint, or it could be, like Dr. Curvilla said, just one joint over, very difficult to say. But we do different things to try to help with that pain. I know people always say, oh, you know, I have a high arch, right? Or my arch hurts. But in fact, we actually have three main arches in our foot. And this is sort of the triangle that they form when you look at the bottom of your foot. The one that's on the right side of the screen that goes to our big toe is the one that we mostly think about as that like inside, the one that we say have high arches. That's usually what people are talking about when they say I have a high arch or I have a flat foot. And that's called the medial longitudinal arch. And we have two other arches that also help give us that cushion and that support. And like Dr. Curvilla said earlier, that transverse arch is kind of where the knuckles of your foot are, where you might add that metatarsal pad to give you a little extra cushion or kind of reinforce that arch that's up near what they call like the balls of the feet. So those are the arches that most people talk about. But there is that arch on the outside part of your foot too. So sometimes people come in and they'll have pain along the outside part of their foot. And they may also have some issues either with tendons, ligaments, or just some irritation on that outside part of the foot as well. And then you have the plantar fascia that sort of runs across the bottom of our foot, and it runs from the heel. And most people that get plantar fascia pain, I think Dr. Curvilla said this is one of the things he sees the most in his office, but most of the pain usually comes in and around the heel because that's where the thickest part is, that's where it attaches, and that's where a lot of the stress and strain comes from when we use our feet and we're on our feet a lot. And then it kind of spreads out and goes up near and towards the toes as it gets more towards the front part of the foot. But it's a very thick area and it kind of covers all those other structures that we just talked about a few minutes ago. So what does it do though? People are always not sure what the plantar fascia does. Sometimes they think it's just a big thick band that's there just to kind of protect everything. It does give us a lot of arch support. So it does help kind of reinforce the shape of the bottom part of our foot. It gives us a lot of cushion and shock absorption. So every time we step down, and Dr. Curvilla talked about what the joints do, and they kind of splay out a little bit, and they almost decompress and flatten out, and then they come back up as we lift our foot off the ground. And that's the cushion. The plantar fascia adds to the cushion as we step down, and it kind of lets those joints and those bones move and then kind of recoil and go back into the original resting position. And that goes along with shock absorption. So every time we take a step, whether it's walking or running, if we jump down on something and we land on the floor, again, it absorbs some of the shock so that it's not going right through our joints, bless you. It also helps to provide a little bit of balance, and then also springboard and propulsion. So that's how, or part of how, we get our forward momentum when we're walking or when we're running. So again, it's like loading and then unloading a spring. So as we step down, everything kind of splays out, and then it helps us to kind of propel or move forward as we're walking or as we're running. Doesn't do it by itself. It's in conjunction with the different muscles in our foot, obviously the different muscles in our body and our legs. But again, it's a big part of what helps to shock absorb as we're walking and running. So when people have flat feet, you can see just standing, normally you would have some sort of like a little bit of an arch. This is that medial longitudinal arch. So when people have flat feet, oftentimes when we see them in the office, one of the first things we'll do when we see them in for an evaluation, let's say, is I'll have them stand up with their shoes and socks off, and I'll just have them stand. And I kind of look at the structure of their feet. And even when you're standing, you should have some amount of an arch. Now, everyone's different, but you should have a little bit of an arch on the inside part of your foot that should be visible. And I'll usually kind of stick my fingers to make sure I can get my fingers under there. If I can't, that's a pretty flat foot. The other reason I like to use this picture is, I don't know if you noticed, but what's the structure that runs up the back part of the heel? The Achilles tendon, right? We've all heard about that. I rarely, if ever, have seen somebody that has either like tight arches, flat feet, and a very loose Achilles tendon. They're very often related. And we call that sort of like the posterior chain or posterior kinetic chain. And so a lot of times you can't just focus on the foot. You have to address all the tightness that they have kind of going up through the back part of their heel and their Achilles and into their calf. Yeah, I mean, a lot of times it's due to trauma. It could be overuse, like just over the course of time. But what you'll notice is the plantar fascia comes all the way back and attaches to the heel, and the Achilles comes down and attaches to the same thing. So that's why it's important that when you're dealing with any sort of foot or especially plantar fasciitis or something like that, that you're also working on loosening up the Achilles tendon, because that's oftentimes, most of the time, it's also very tight. And if you don't address that, it's probably going to come back. So they're very much related when you're dealing with that condition. So how do these injuries occur? Overuse, it could be somebody who does a lot of walking, a lot of running, a lot of hiking, just is on their feet a lot for work. Construction workers sometimes who don't wear good shoes, which we'll get into, can develop this over time. Trauma, so sometimes landing, if you fell off a ladder, fall off. Again, it doesn't have to be something high. It could be something that's not that high, but you can injure it that way. Just excessive load bearing. So again, we talked about different jobs or poor footwear. So if you don't have shoes, sneakers, work shoes that support your feet, that can also lead to some issues. And it doesn't have to be big, heavy people that develop plantar fasciitis. It could just be a runner, very light runner that is either wearing poor shoes, lots of mileage that they're putting in. Maybe they're a long distance runner, and that can over time cause pain. Or it could be somebody that just in their job is constantly carrying extra load. So you think about firefighters who have to carry the hoses, right? A lot of extra weight. Construction workers that are often carrying, whether it be rebar or something like that on work sites. That extra load is going through that cushion, that support, that arch support in our plantar fascia. Sure, absolutely. It's probably maybe felt better. Yeah. So these are the different treatments we can do. If you come in for therapy for this, we do work on the soft tissue air side of things. So we'll work on the plantar fascia itself. We'll do some joint mobilization, lots of stretching. There's different modalities that you can do. These are just some that are out there that are become more popular for the treatment of plantar fasciitis and shockwave therapy and some dry needling. And then over time, what you want to make sure we do is reinforce the arch by doing some strengthening. So all those very small but many muscles in our foot help to kind of build and reinforce the arch in our foot. And when they get weak, sometimes what happens is it allows that foot to be flatter and not as well supported. So strengthening becomes a big thing, but not right away, because if you strengthen a really sore foot and you do exercises for sore muscles or sore plantar fascia, it can just create more irritation in that area. So usually that's a little bit down the line. in real severe cases, sometimes you'll hear that people will wear some splints at nighttime just to kind of get a stretch. Because at night we tend to have our feet relax and our toes kind of curl. And so we wake up and take that first step. If you've known anybody that's had plantar fasciitis and you ask them what the worst part of their day is, they say it's the minute they step out of bed and their feet hit the ground because they've been sort of relaxed all night and then they stretch that first time their foot hits the ground and it could be very uncomfortable.
On the footwear, is the arch support more important or the padding, or the heavier padding for shock absorption?
Yes. It depends, and we'll get into why. Because it can be that you're trying to cushion the heel where a lot of your pain is, and that may help one person, and then the other person might have a condition that's like mechanically or structurally, it's so much more involved in the arch that they might benefit more from better arch support. So that's why what I'm going to get to in a minute is it's really important to make sure you personally get evaluated for what would help you the most, because it may be different than the person who has the same sort of condition, but maybe not for the same reason. Does that make sense? It'll make sense when you see a little bit more of the pictures of the shoe. And then we'll talk about shoe wear patterns. Sometimes these people that have plantar fasciitis or other foot conditions will look at the bottom of their shoe. There's a particular wear pattern that we should see, that we hit our heel first and we kind of move up the outside part of our foot and then push off our big toe. And if we're not seeing that pattern, that means they're compensating. They're trying to avoid their foot hurting. And so they might be walking more on the inside part of their shoe to try to avoid pressure or something like that. So,
Question.
Yeah, sure.
Modalities.
Yep.
Do those treat some of the other issues that we say, like muscles.
it's a great question. I'll have Dr. Curvilla answer that maybe at the end, because that's a good question, because he went through a bunch of different conditions, and I don't want to speak for all of them because I wouldn't have the right answer for all of them. So, and then again, prevention is important. Make sure you're doing a lot of warming up, stretching, gradual ramp up. This is probably what I see the most in physical therapy. People, they say, well, I decided to pick up running and I started running too much too soon. Or we see it a lot during season transitions. They go from indoor track to outdoor track, some of these athletes, and just the different surfaces can affect that. So again, gradual ramp ups are important, and then making sure you're getting plenty of rest and recovery. And then the great toe, I wanted to bring this up because this has been in the news a lot. If any NFL football fans in here, we know that turf toe has been a big thing recently with some very popular high-profile quarterbacks across the league. So the great toe is another area that can become a problem that we see a lot in physical therapy. And this was, some of the conditions that Dr. Curvilla talked about with bunions and hallux rigidus. So again, not a super simple part of the body. I put this up here just so you can see. It's not like just, a couple of bones and a muscle. There's a lot of different ligaments and tendons and muscles that are around the big toe that can be affected. And what are the functions of the great toe? Very simply, a lot for balance. It also contributes to some of that arch support that we talked about earlier. We saw how that plantar fascia goes up right towards the toes. So they attach it attaches near the big toe, which again, the big toe will help in arch support. And it also helps in that propulsion, proper gait mechanics, and walking and running. So there's been a couple of quarterbacks, like I said, this year that have developed turf toe. In San Francisco, Brock Purdy has been out for a couple of weeks, but he's supposed to be back this week potentially. Joe Burrow, same condition, but a much more severe mechanism that he had, and it's at a much greater level. So he's going to require surgery and be out probably most of the season, if not the entire season. So why the difference? So what is turf toe? Turf toe is when you injure that ligament tendon along the bottom underneath side of the big toe. So in Joe Burrow's case, he had a complete rupture of that structure underneath the big toe, and it's going to need to be surgically repaired. But you can develop turf toe more from like an overuse mechanism and just create some irritation under there that requires some rest that would then essentially heal it up, over some time. But usually you have to be off of it and give it a rest, and also get some treatment on it as well. Yep. Well, it depends on the severity. So when you have a condition like Joe Burrow had, where it's a rupture, it can become unstable in the joint, and then it can affect other things in the foot other than just that big toe. Tear, yeah, like a complete tear. I think so. Yes, exactly. Yeah. So how does this happen? It could be overuse. So you can develop this from, again, like running or jumping, repeated trauma, like in a football game, where they call it turf toe because back in the day, on the AstroTurf, it was much less give. Now they use a lot of the field turf. So even though they're calling this turf toe, it's probably not the turf now that's causing it, but it's that mechanism of like hyperflexing, or we call it dorsiflexing, that big toe. And when you can do it traumatically, like one big push and it can tear, like what happened to him, or it can be repetitive over time that can happen like with a runner. Or it can be excessive load bearing, or again, for poor footwear. Treatment's very similar to what we talked about with plantar fasciitis. A lot of it, you just have to let it settle down, and then we want to work on the soft tissue mobilization, joint mobilization, to make sure you don't get a stiff joint afterwards. So do some stretching, some modalities, and then ultimately some strengthening in order to get you back to whatever your activity is. It could be work, it could be sports, it could be just walking around, being able to move around without pain. And also similar prevention, making sure you're warming up and stretching good, gradual ramp up so you don't create irritation in and around that joint, and then wearing good footwear. And sometimes you have to modify your activities too. So if you're like, again, you're keeping players out for a couple weeks until this settles down, and again, if you can rest and recover in between, that also is helpful as far as. So we'll talk about it. So the stretches first. So whether you're dealing with turf toe or plantar fasciitis, these can all be sort of helpful. That's why I put these two conditions together. And these stretches are ones that you can do. And we talked about it's not just for the bottom of your foot, it's also for the Achilles and up into the calf muscle. So on the upper left, that's a regular sort of a calf stretch. The one on the upper right is similar, but if you'll notice, her back knee is bent a little bit, and that's going to stretch some other muscles in your calf, which are important, that often are missed when people do stretches. And they are more on the outside part of your calf as opposed to right in the middle and a little bit lower. And then you have on the bottom left, it's kind of off a step where you get a little bit more of the toes involved in the stretch. So you get a little bit more of the bottom part of the foot, so the plantar fascia and the big toe. And then similarly here, you can see this gentleman's really got the toes kind of pushed back. So you get a little bit more of a stretch in the plantar fascia and under the big toe as well. Some simple strengthening that we do. Again, you could do something like heel raises where you're just going up and down on your toes, strengthen the calf and the soleus muscle in the back there. We do a lot of towel crunches to strengthen the muscles in the foot, which help reinforce the arch, which we mentioned earlier, that it's hard to strengthen foot muscles because there's a lot of them and they're very small. So we typically do big foot movements and motions like grabbing a towel, picking up marbles like this, all work on some of that dexterity in our feet, try to get those muscles to work. And balancing, believe it or not. And if you can try this, if you just stand on one foot and if you start to lose your balance, anybody know what you feel when you start to lose your balance? Your toes grab because they're trying to hold you and trying to keep you balanced. So even just doing some balance work will actually build up some of the strength in your feet. All right, so shoes. You've got your big, thick soles, even into the midsole have gotten really big, and even in the forefoot have also, in the last couple of years in particular, this is the thickest pair I could find. Some are not as thick as that, but a lot of them are getting like this. And sort of the minimalist was, not that long ago, and there's different theories behind which ones work. And I'm happy to talk about that offline. I want to make sure we guys get you out of here somewhat on time. It just depends on what your specific needs are. I will say, people said, oh, I don't know about the minimalist shoe. Well, if you've never worn one and you've always had pretty thick or cushioned shoes and you suddenly start to use those, that might be too much of a change for your feet and they might actually hurt your feet. But the theory is that they force your muscles to work more so they get a little bit stronger. You'll get better arch support. And over time, it could be better for your feet, which I don't disagree with. So it's all gradual, it's all relative. And some people, if you have issues with your feet, wouldn't tolerate that. So your best bet might be to be in a more cushioned supportive shoe. Hoka is just one brand, but like I said, lots of brands are using that thick sole now.
I just got a question. Say I'm wearing orthotics and I was told to wear like a stability shoe. Now I'm hearing like maybe I should be wearing more of a neutral shoe. I've been wearing orthotics for 30 years.
Yeah.
And I'm just curious to what your opinion is. I've been wearing Brooks Beats forever.
Yeah, I think it depends on, I guess I need to know exactly why it's being recommended that you wear a more stable shoe. Because I'm the same way. So I have my forefoot and my midfoot have become a little bit deteriorated over time. I did a lot of running, high school and college. So the first thing I do when I pick up a shoe, if I'm going to buy them, is I turn them and I try to bend them. And if I can bend it really easily, there's not enough support there. Yeah, exactly.
So I had a drop foot like
Yep. So, that may be why you need a more rigid shoe so that you don't get as much play in the joints. But again, you'd have to probably understand exactly why.
Yeah, I've been versus I need.
There you go. So these are the different parts of the shoe. So just to kind of go over again, the crash pad is in the back. That's what's become real thick in the last couple of years. So for people that have heel pain, that has helped a lot for again, whether it's plantar fasciitis or just kind of wear and tear. That could be a nice way to kind of soften up if you're just doing a lot of walking or running. The midsole again, and then towards the front is more the forefoot, but everything on the bottom is considered the outsole, and then they still have that inner sole, which can have a bit of an arch. It can be a little bit less of an arch. Again, every shoe is a little bit different, and what you need in particular is probably dependent upon what your feet are like and what your needs are. Everything on top is not as important, but that's just like the basics. So, sports specific, people sometimes don't realize how important it is that you have the right shoe for the activity that you're doing. Who wants to tell these don't look that different, but who wants to tell me the difference between the shoe on the left and the shoe on the right? Anybody see anything obvious? Yeah, especially in the middle, right? On the walking and the running shoe, you can see it gets real narrow in the middle. And then on the tennis shoe, or I call this a court shoe, right? It could be a pickleball, it could be tennis, could be racquetball. It's going to stay a little bit wider because you need a little bit more of that lateral stability when you're moving around. So you'd be more likely to kind of roll your ankle if you try to play tennis or pickleball on a running or walking shoe because there's not as much of that lateral support. Okay. Running and walking shoes are really meant for that straight ahead, forward and backward kind of motion. There's not as much side to side. Unless you're doing trail running, then you'll see on a trail shoe, the sole will be wider, the bottom will be more contoured so you get better grip. So sometimes the first thing I'll do is kind of flip over the shoe and see what does the bottom look like. So if I'm going to be on trails, I want something that's a little bit more contoured. But you can see a huge difference here in a walk-run shoe versus a court shoe. Wider and flatter, right? More stable. So when you're going side to side, you have more of that stability to kind of protect your foot and ankle. Or versus a running or walking shoe where you're not doing a lot of side to side, or you shouldn't be, and it's more that sort of like forward direction, forward backward direction. Okay. Does that all make sense? So just some quick take-home points. Most foot and big toe pain is preventable. Again, a lot of stretching goes a long way. Making sure that I always see the biggest cause of foot pain tends to be a quick onset or a quick change of activity or a quick ramp up of walking and running. We see a lot of injuries first thing on that sort of spring to summer transition because people go from wearing shoes all winter to then all of a sudden wearing flip flops or walking around barefoot, and people complain about foot pain a lot more often. So that transition of seasons, we get that a lot too. Make sure you have proper shoes. There isn't a one size fits all, but it is important because everybody probably has a different need. Like to your point, you need a more stable shoe. I need a more stable shoe. Other people don't need a stable shoe, but they might need better arch reinforcement in their shoes. And so some shoes have better that medial arch support than others. Some people might benefit more from that heel cushion. So it just depends. It's important to get checked out so you know what to ask for. So whether you see a podiatrist like Dr. Gravilla, see a physical therapist, if you're already in physical therapy, just ask them what they think based upon your foot structure. Some shoe stores are very good at sort of evaluating what your foot looks like and giving you some recommendations as well. Some of the big box stores, not as much, but there's a couple of specialty stores around that might be able to give you some guidance as far as what's best. So that's why I definitely recommend asking a professional because it is different. That's the end of my talk.